Non-medical prescribing case study presenting by Shen Ying Wan. A 50-year-old man presenting dysphagia. Patient has been suffering from a long-term severe acid reflux. No weight loss. Patient was referred by GP on a 2-week wait cancer pathway for upper GI investigation. Past medical history. Rheumatoid arthritis. Patient has been on ibuprofen 1.2 grams daily for a couple of years. A gastroscopy was performed, grade C esophagitis, with 3 small ulcers seen in the gastroesophageal junction. 6 cm hiatus hernia also noticed. The rest of the upper GI tract was normal, CLO test negative. Esophageal biopsy later showed ulcerative esophagitis. Non-steroid anti-inflammatory drugs and peptic ulcers. Peptic ulcers is defect in the upper gastrointestinal mucosa that extend through the muscularis mucosa into a deeper layer of a gut wall. There are 2 major risk factors reported. H. pylori infection, which in this case was excluded by a 5-minute CLO test, negative during the procedure. Number 2, NSAIDs, including ibuprofen, can cause ulcers by interfering the stomach's ability to protect itself from gastric acid. A long-term use of NSAIDs and severe acid reflux could be the cause of a grade C esophagitis with small ulcers. In this case, diagnosis and prescribing decision based on NICE guidelines: 40 mg omeprazole orally once daily for 8 weeks was suggested. Taken 30 minutes before meal, and a ray-scope was requested in 6 to 8 weeks time to check healings, then continue and take a long-term low dose of PPI as a prophylaxis. Patient confirmed no other drug allergies beside penicillin before prescription. Omeprazole was one of the proton pump inhibitor, which was introduced in 1989, targeted at gastric H and K ATPs, and reflected a major medical therapeutic breakthrough in treating peptic ulcers and gastroesophageal reflux disease. Pharmacokinetics and pharmacodynamics of PPI. Proton pump inhibitor is inactive in their native form. They are initially absorbed via a small intestine and distributed to gastric parietal cells, where they are activated in acidic environment. Activated PPI binds covalently to gastric H and K ATPs, while sulfified band PPIs are rapidly metabolized by liver and eliminated from the blood. All PPIs have about 1 hour of a half-life. PPIs is prodrugs. The presence of acid secretion is necessary for the actions. It is also important to keep the PPI plasma level high until gastric acid secretes. Therefore, it is recommended to be given 30 to 6 minutes before meals. Ensure the pumps active. Non-medical prescribing. Non-medical prescribing is a new concept initiated by government plans to modernize the NHS. Study shows that NMP was well accepted by patients and many other health professionals, based not just on the level of satisfaction from the endoscopy practitioners, also perceived values for the endoscopy service as a whole. In this case, patient was diagnosed with a grade C ulcerative esophagitis, was given a prescription immediately, so the treatment starts the same day as its procedure. That would limit any delays in his 6 and 8 weeks rescope to check healings. WHO has stated insufficient therapeutic effects would result in prolonged hospital treatment, which can waste health resources. Time consequently has a negative impact on the NHS. Within the endoscopy environment, non-medical prescribing would enable a smoother patient journey and more consistent, flexible, patient-oriented care. The law as it applies to non-medical prescribing roles. The Cambridge Report 1989 was the first document to make a recommendation for nurses on the role of prescribing. The Prescription by Nurse Act in 1992 provided power for nurses to prescribe. The second Crown Report in 1999 has extended the prescribing rights and responsibility to other health professionals. When prescribing medication, the prescriber is judged against the standards of an experienced prescriber carrying out the role. The Department of Health 2006 confirmed prescribers are accountable for every aspect of their decision-making. The WHO defines the rationale of using medicines as giving the right medicines for the right patient at the right dose for the right duration at the right cost. It's also important to recommend the law related to consent, confidentiality, and record-keeping also apply to non-medical prescribing role. Ethical considerations. Prescribing is challenging. It is required a thorough knowledge and understanding of the physiology of a disease and the pharmacology property of relevant drugs. According to WHO, essential medicines are one of the most cost-effective ways of saving lives, improving health. Medication errors occurred in all healthcare settings, no matter how good the staff are at prescribing, dispensing, or administering medications. Even with zero staff errors, patients may take drugs incorrectly. Causes are numerous and including lack of knowledge, tiredness of staff, careless work attitude, poorly explained policies, unfamiliar dosage forms. Medication errors is probably the most preventable type of error in endoscopy settings. Of all types of medication error, prescribing is the most serious. It can cause significant harm and death. Education about prescribing guidance have been proven to reduce total errors by minimizing risk. I should consider the best interests of patients and practice to high standard. These principles can be transferred to my future daily endoscopy practice. If any prescribing error occurred, that will be detected, and I will make sure of learning from any mistakes. For example, taking PPIs is reported associated with mortality, including death due to cardiovascular disease, chronic kidney disease, and upper gastrointestinal cancer. Therefore, I will regularly check MHRA updates on drugs and their adverse effects. As a qualified non-medical prescriber, I should prescribe only medicines I know to be safe, effective, and appropriate. Professional responsibility. Once I'm qualified as a non-medical prescriber, I have a duty of care to keep up to date with how these regulations are amended and with ongoing safety profile as applied to NMC 2006. I will be liable for my actions and accountable for keeping my skills and knowledge up to date. Appraisal, critical incident analysis, reflection, and objective data are available with my current practice. They have been well used by my previous non-medical prescriber colleagues, will be used by me in order to support my future CPDs. Competency framework are useful tool for self-assess and identify CPD needs. In my current trust, an audit showed a post-qualification and a high majority participant being able to maintain a wide range of competency with the prescribing roles. Accountability of prescribers of the employers. My contract of employment outlines instruction of my current NHS trust. I will follow these instructions with appropriate level of care and skills. There is evidence of negligence. My employer has the right to exert disciplinary power. Once I'm qualified as a non-medical prescriber, my employment contract and job description should be reassessed and amended. Adding to prescribing duties my employer wishes me to hold. Similarly, the process needs to be in place to ensure I maintain competence with the role. The employer has a duty to develop and uphold this. Previous non-medical prescriber reported they were much clearer about their own professional boundaries once they have completed a prescribing course. Continued professional development. The aim of CPD should be to improve healthcare delivery and meet service needs. Pharmacology and prescribing is rapidly changing. That requires nurses manager to ensure staff engaged in non-medical prescribing receive regular CPDs. Otherwise, non-medical prescribing is a relevant new innovation to the NHS. Therefore, those who is not medically qualified need a mentorship from experienced prescriber plus encouragement to be competent prescriber themselves. NMC 2004 established a standard requirement to undertake 35 hours of learning in the 3 years prior to review registration. Delivery CPD or request support and guidance for the senior pharmacist working in my own trust. To address key pharmacology, pharmacy prescribing, medication management, education, the development of a portfolio is required to be reviewed, updated on a regular basis. CPD should include multiple approach, including workshop, study days, covering such as clinical skills training, legal issues, prescribing updates, exploiting local and informal non-medical prescribing network, attending medical conferences, e-learnings. In the practical turn, direct clinical supervision feedback are also crucial. Nurses manager needs to play an active role by addressing any training gaps during the appraisal. The next 4 pages, it will be the references, Thank you.